Thank you, sir. Those words were much needed and I think very correctly underline the concerns of the program. And we will continue to look for your guidance under the IPAC premise and seek guidance from you and Dr. Sasteva. Thank you very much. I would like to now ask Dr. Madhukar Pai to begin his presentation on TB diagnosis, state of science. Thank you.
Good afternoon, folks. Thank you so much for taking the time off on a weekend and coming. Before I get started, if there are any clinicians in the room, please, we would love to see your CME questionnaires filled out, and Manjot and Karthik will collect them from you. It's very important for us to know what the practices are, and then I will come back to those questions during my talk. Before I begin, a disclosure slide. I have no financial interest in any commercial product. No lab, no company has had any influence on my presentation. So, as Dr. Gupta was just mentioning, it is really critical for us to ask the simple question, why does early and accurate diagnosis matter? And it matters because of this very interesting piece of data. We published this paper in IJTLD 2 months ago on a systematic review on all studies from India on diagnostic delay in TB. And the bottom line was, an average Indian TB patient is diagnosed after 2 months of delay and after having seen 3 different providers. And 50% of patients initially sought care in the private sector. This is data from more than 20 studies from across India. This is not my data. It is a meta-analysis which summarizes as 2 months of diagnostic delay is completely unacceptable. And why on earth should people see 3 different doctors before TB is diagnosed? Why can't the first doctor order a sputum test, diagnose TB, and get it out of the way? Why are they bouncing from person to person and finally ending up in the dots several months later with advanced cavitary TB, by which time they've already spread the infection to 15 other people in the community? This is exactly why transmission is not going down in India. That's exactly what Dr. Gupta was saying we need to avoid. Number 2, accurate diagnosis is absolutely critical for MDR. As Dr. Zarir Udwadia likes to point out, it only takes 2.1 errors in prescription to convert a drug-sensitive case into a drug-resistant case. Not getting drug susceptibility early and not knowing what we are treating, just keep on adding one drug to this failing regimen is a disaster for TB patients. That's how we have MDR and XTR and whatever else is coming down the pipeline. So the objective of my talk is to discuss with you the best practices for diagnosing TB internationally and nationally for active TB, drug-resistant TB, and latent infection. I will cover the international standards of TB care, which is being released tomorrow, the 3rd edition, in which I was a member of the steering committee. I will also mention WHO policies, but I also know that the Indian standards for TB care, STCI, will also be released tomorrow. So I will update my talk once that is out, but by and large, these standards are all fairly consistent. There are not too many big differences between the international and the Indian standards. So, I'll first talk about pulmonary TB, which is the bulk of all TB that we see in India and elsewhere. And I think this is the most important standard within all ISDC standards for diagnosis. All patients, including kids, with unexplained cough lasting 2 or more weeks, or have an abnormal chest X-ray, should be evaluated for tuberculosis. If this happened at the first visit, there is no reason to see 3 different doctors. And this is exactly what is not happening in the private sector. People are going in with 2, 3, 4 weeks of cough. They're getting everything but a sputum test for TB. They're getting antibiotics, broad spectrum, they're getting levofloxacin, they're getting placebos, they're getting cough syrups. Nobody is testing them for TB. By the time the TB test comes along, it is fairly down the stream. Several days have already passed by. So in terms of diagnostic options, to put it simply, there are only 3 ways of diagnosing active TB. You either see the bug, you grow the bug, or you multiply the bug. There is no other technique that anybody knows of on how to diagnose TB. In terms of microscopy and molecular test, this is the ISTC recommendation that all patients suspected as having TB should have at least 2 sputum samples submitted for smear microscopy or a single sputum for gene expert in a quality assured laboratory. Patients at risk for MDR or have HIV or seriously ill should have expert performed as the initial diagnostic. Blood-based serological test and interferon gamma release assay should not be used for the diagnosis of active TB. So if I were a microbiologist, and there are a fair number of microbiologists in the room, this would be the dream setup for smear microscopy. This is the best microscopy anyone can offer to any patient. LED microscopy, fluorescence staining, 2 samples, read by a trained technician with external quality assurance. If you can do that, this is the max juice you can squeeze out of microscopy, and it should be done as much as possible in the private sector. This is the data from Central TB Division and FIND, published in the last few months actually. LED microscopy definitely outperforms standard Xenius microscopy. Case detection is increased by more than 20%, and essentially the RNTCP now recommends that all people should switch from standard Xenius to LED microscopy. The next major advance, as you know, everybody knows by now, is Gene Expert, which is a completely automated molecular diagnostic system for TB. And this is a WHO policy on Gene Expert that was first published in 2011 and updated and published last year, 2013. To put it in very simple language, the WHO is saying, if resources were not a problem, then Gene Expert is the #1 test for TB. But they know resources are a problem. So they are saying prioritize 2 groups for Gene Expert. Anyone with suspected MDR, anyone with HIV should be prioritized for Gene Expert. But if resources permit, then Gene Expert can be the start test for anyone with TB. The rollout of Gene Expert has now crossed 5 million cartridges as of the last time count. Dramatic scale-up is happening, especially in countries like South Africa and many other countries. And it is based on fairly strong evidence. So this is the Cochrane Systematic Review that we first published in 2013, and we again updated based on a large number of new studies and published in 2014. In essence, the test picks up 88% of all culture-positive TB with a specificity as high as 99. It practically picks up every single smear positive case, which is not surprising, but it also picks up almost 70% of smear negative TB, which smears by definition will never pick up. If used as a DST, it is picking up 95% of RIF resistance with a specificity of 98. And this is the evidence from India, published recently by CTD and FIND and colleagues, that it is possible to implement this technology even at a decentralized level. It has been put in microscopy centers in 18 TUs across India, 99% valid results with low failure rates. And the data that has been presented in meetings but has still not published, will hopefully be published soon, shows substantial increase in case detection of bacteriologically confirmed TB and an increase in rifampicin case detection. So Gene Expert is the start point for many of us now, especially in the high-risk groups of MDR and HIV-infected people. What about extrapulmonary TB? The private sector in India is genuinely very concerned with extrapulmonary TB. I have not met a single private sector person who's not been worrying about EPTB. I don't know why that is. Maybe it's a referral bias. PTB tends to go to public sector and EPTB goes to private sector. I don't know why, but everybody is more concerned about EPTB here. So the international standard says for all patients suspected as having EPTB, appropriate samples from the suspected site of involvement should be obtained for microbiological and histological examination. An expert is a recommended preferred initial test for suspected TB meningitis because of the need for rapid diagnosis. So clearly you have to suspect EPTB to start with. Number 2, right sample from the site of the disease. I cannot emphasize how critical that is. The myth in India is that extrapulmonary TB can be magically picked up by peripheral venous blood. There is no such thing. Nobody in the world has come up with a biomarker that magically tells you from venous blood where extrapulmonary TB is lying. No, we have to put a needle or something at the site of the disease, get a tissue, get an aspirate from the site, and send that for microbiological confirmation. So smears should be done without too much hope. By and large, smears are negative in EPTB, but should be done. But NAT and GeneXpert should definitely be useful. Cultures are extremely helpful in extrapulmonary TB. Yes, we have to wait for 2 weeks, but it absolutely can add value. Histopathology is very, very helpful. If you have a trained pathologist to look at this slide, extremely helpful. If nothing works, and there are lots of cases where nobody can find anything, then you have to do empiric trial of anti-TB therapy. There is no role for any blood test for extrapulmonary TB. So here are the WHO recommendations on expert for EPTB, that they clearly find evidence that it should be the #1 test for cerebrospinal fluid and TB meningitis. Within 90 minutes, you have a fairly good indication of whether it's TB or not. And as we all know, TB meningitis is a medical emergency. There's no time to waste in TBM. The WHO also recommends expert as an initial test for lymph node and other tissues based on this evidence. So this systematic review, again by our team, will be published in European Respiratory Journal, hopefully in April. It's already been accepted. This is the sensitivity specificity of GeneXpert against culture. For lymph nodes, you can see sensitivity is 83%, specificity is 94%. CSF, 81%, specificity is 98%. Pleural fluid, unfortunately, is one specimen where GeneXpert does not pick up a lot, either because there isn't enough bacteria there, or there are inhibitors in pleural fluid. But pleural biopsy, if possible, could add value, because generally GeneXpert seems to perform better in tissues than in aspirates. So in short, for pleural fluid, the sensitivity is low, so do not use it as a solo test. For CSF, it's very highly accurate, therefore it should be used. And lymph node, the performance is very good, should be used. Liquid cultures, as I said, is the gold standard. It is the best, most sensitive test we have. And not only does it diagnose TB, it will also pick up drug resistance. It is the only technology we have that can actually assay all drugs that are critically important. It's an ideal test for smear negative and extrapulmonary TB. 2 weeks is the turnaround, which is the only real negative, and now it's much more affordable than it was in the past. What about immunological tests? As Dr. Gupta mentioned, these tests have no real role, nor does MAN2 test have any role for active TB, and I will come back to this issue a little later. In children, MAN2 or IGRAS could be helpful as evidence of infection, along with chest X-ray symptoms and history of contact. So WHO has recommended against serological antibody tests as well as IGRAS for the use of active TB, and that's exactly what the RNTCP has done as well. So again, as of today, until somebody comes up with a validated, accurate biomarker in the blood, blood is not the sample for active TB diagnosis. Sputum is the sample for active TB diagnosis, or something from the site of the disease that one can culture or do specimen on. So I would again plead with my private sector colleagues that peripheral blood is not the right compartment as of today for diagnosing active TB. Drug resistance testing is critical. ISTC says anyone who has previously been treated or anyone who is not responding to standard TB must receive drug susceptibility testing. So there are multiple options here. Among cultures, one can do solid cultures, which unfortunately come too late to help the patient. It is of very little clinical significance. Liquid cultures, unfortunately, are significantly underused in India. I mean, if you look at the number of liquid cultures done in private sector, is so pathetic that you wonder what on earth is going on. I can only think of 2 reasons why liquid cultures are so undervalued in India and the private sector. Number one, I think many of us are still thinking solid cultures in our head. We were so used to hearing that cultures will come after 2 months, therefore it's of no real use to anyone. Well, liquid cultures come after 2 weeks. Can we not wait for 10 days and get a good quality assured result? We can, but people just don't seem to have the patience to wait it out and get a culture report. Number two, liquid cultures were always thought by everyone as being too expensive. That is another reason often given that our patients can never afford liquid culture and DST. Hopefully both are changing now, because it is the only technology we have that can genuinely give us a complete drug susceptibility profile, without which we really cannot treat MDR. Line probe assays are excellent as rapid molecular tests, WHO approved in 2008. That is the meta-analysis we published several years ago. 98% sensitivity and 99% specificity for RIF resistance. INH sensitivity is always tends to be lower, 84% and 99% specificity for INH. But if a line probe assay is positive, one can confidently begin MDR therapy while waiting for liquid culture and DST to come back. This is a study from CTT and FIND published very recently on a multi-site validation of LPA. Very, very accurate for rifampicin resistance, less accurate for isoniazid as expected, but pretty much rifampicin resistance is an excellent marker for MDR in India. Once you know somebody's RIF resistance, they're highly likely to have MDR, and that's a good start point while waiting for liquid culture and DST. And as I mentioned, EXPERT is also a rapid DST test, and RIF resistance is a very strong correlate of MDR-TB. There are a lot of people who seem to be concerned about INH resistance. And we know INH monoresistance is a problem in India, but by and large, once RIF is positive or resistant, most clinicians should accept that as a marker of MDR, begin what they need to do for MDR therapy, but wait for liquid culture and DST to come back and then modify the treatment regimen accordingly. So this is the recommended algorithm for DST in the International Standards of TB Care. Anyone with suspected drug resistance that has previously been treated, not responding to standard therapy, should get a rapid molecular test. If RIF is positive, one can begin MDR therapy while waiting for culture and DST. So in other words, no molecular test, it's an end in itself. Molecular tests are the start point. One has to wait for culture DST to come back to finally decide what the right regimen is for that given particular patient. Then once the culture DST comes back, you can modify the treatment, change the drugs depending on which ones are sensitive or resistant. Lastly, I want to finish off by talking about this very confusing animal in India called latent TB infection. Most of us, especially if we were to do a man-2 test on everybody in this room, I think there's no prices for guessing. Virtually every one of us will be positive because we are healthcare workers, we are trained in medicine, we've been exposed to TB throughout our training. So most of us are exposed to TB, we convert our skin test or our TB gold, and we never develop active TB. The immune defenses contain it. That's latent TB infection. One has an indirect immunological evidence of sensitivity to prior exposure to TB. But that does not mean we actually need 4 drugs to treat active TB. The goal of detecting latent TB, which is widespread in countries like US and Canada. I mean, in Canada, this is all we do every day. We don't have active TB, okay? We have to search hard to find one case of active TB, but we have lots and lots of people with latent TB. We detect them and we give them 6 to 9 months of isoniazid to prevent them from developing active TB in future. In other words, prophylaxis is what we are really intending to do when we detect latent TB. And there are certain risk groups where prophylaxis completely makes sense. Children under the age of 5 who've been exposed to an adult with TB is a very, very important group because if we don't prophylax them, they will definitely end up with active TB. Anyone with HIV infection who's highly vulnerable to progress to active TB is at high risk. Anyone who's immunocompromised for any reason, TNF-alpha blockers, cancer chemotherapy, radiation, people who have had organ transplants, all of them are high risk for going from latent to active TB. In these high risk groups, if you do a test for latent infection, you've ruled out active TB, you give isoniazid for 6 to 9 months, you can prevent 60 to 90% of them from progressing to active TB. This is the real role for detection and management of LTBI. How do we test for LTBI? That is the old man-2 test, or there are these new interferon gamma blood-based assays, quantiferon TB gold, TB platinum, T-spot TB. All of them are acceptable as tests for latent infection. But none of them, including man-2, can really separate latent infection from someone who is a smear positive or a culture positive active TB case. Therefore, they cannot be used for active TB, especially in a high burden country like India, where 40 to 50% of Indians have evidence of latent TB infection. Now, we asked the simple question. Remember the questionnaire that you've all filled out now? We have done it in many other cities. IPAC has done these CMEs, Hyderabad, Mumbai, Chennai, and Kolkata. We asked the simple question, how many of you clinicians are actually detecting and treating latent TB infection with 6 to 9 months of isoniazid? The answer is almost never. Right? And I think that would be the same phenomenon here. Indian physicians do not generally treat latent TB with 6 to 9 months of isoniazid. If that is the case, why on earth are they ordering TB Gold and Platinum? There is a complete mismatch between what they are asking and what they are actually doing. If the goal is to actually treat latent TB infection, fine. Do a TB Gold or whatever it is and do 6 to 9 months of isoniazid. But if nobody is treating latent TB, then what is the disconnect between what they're ordering and what they're practicing? It's a fundamental confusion. All I can think of is they have been misled into believing that these tests are for active TB, which they are not, and they can never be used for active TB. So that is the key message for my talk. Neither MAN2 nor IGRAs have any real role for active TB diagnosis. Active TB is a microbiological diagnosis as of today. There is no immunological tool that we know that can pinpoint and say this is active TB that requires AKT4 or whatever it is. Active TB continues to be a microbiological diagnosis. Therefore, sputum tests, gene expert, LPA, smears, culture is the right way to do. If at all anyone wants to treat latent infection, which is perfectly fine in those high-risk groups, you should rule out active TB before giving 6 to 9 months of isoniazid. Otherwise, it's disastrous. We are treating active TB with one drug and we are setting up the patient to develop drug resistance. So in conclusion, we need to actively look for TB in everyone with 2 weeks of cough or abnormal chest x-rays. We should be using sputum tests, smears, expert, LPA, and liquid cultures, not blood tests. For EPTB, we have to get a sample from the site of the disease, not use peripheral venous blood. And everyone with a previous history of TB or not responding to therapy must undergo drug susceptibility testing. And WHO approved tests are now available through this IPAC initiative at much lower prices. So just to quickly round off and say what on earth IPAC is, Clinton Foundation some years ago realized that there was a big gap in the Indian private market. The serological tests got banned, but WHO approved tests were extraordinarily highly priced. So there was a big void or need in the market to bring the prices down so that private practitioners could use these tests. And I remember there was a meeting held, Dr. Sachdeva was there, I think in June of 2012. CTD was there, WHO was there. We invited all manufacturers in one room, all major labs in one room, and we posed the question, we have to do something about this problem. So the diagnostic manufacturers said, yes, we're happy to extend a lower price to the private sector, but they will still charge 4 times, 5 times the price of the product. So all the private labs in the room said, no, we are willing to pass on the benefits to the patient, provided the same transparent deal is cut across all private labs. That was, I think, the magical moment when we realized that we could bring a coalition together and make this work. And CHAI finally managed to pull off. It required 5 MBAs from CHAI to do this. And so they did it. So they brought all of these people together. All the WHO approved manufacturers who are in this room kindly agreed to pass on the same public sector pricing to the private sector. All the labs have to sign a charter saying they will in turn not charge more than a transparently agreed ceiling price, that they would agree to all of the conditions, and that's how we came up with this. And the goal is all parties will win. The companies will win because their volumes will go up. They've made a product more affordable. Labs will win because they now have a replacement for serology that is affordable for the patients. And RNTCP will gain because of notification and greater awareness and partnership with these labs. So that's how we created this initiative. That's the current pricing. So Gene Expert cannot be sold for more than 2,000 rupees in any of the IPAC packs. LPA is 1,600 rupees. Midget and Back the Alert is 900 rupees for culture. It's slightly higher for DST. Patients can be charged less, but cannot be charged more than the transparent ceiling price that we have. Any private lab in India can join IPAC, provided they are accredited. They have to be accredited by somebody. Number 2, they have to agree to notify cases to the RNTCP. They have to agree to be part of an external quality assurance program that we are setting up right now, and only accredited labs can join IPAC as of now. Where are we now? We have reached 64 labs. We started exactly a year ago, I remember, around World TB Day, and I'm just thrilled beyond words that we've even reached this number. If somebody had told me we would reach this in 1 year, I would have been very surprised. We've done it. All the major chain labs pretty much are involved, plus many medical colleges are now involved as well. We're also hoping, and really hoping, and I'm pleading to people in this room, that we love to see corporate hospitals join this initiative. We want the Medantas, the Fortis, and the Max, and the Apollos very much to be a part of the initiative, and private medical colleges as well to join IPAC. Now look at the amount of increase in tests from almost 500 gene expert tests until IPAC started to more than 22,000 gene expert tests after IPAC has been introduced. Dramatic increase in the number of tests, but still we have a long way to go. For a country of India's size, these numbers are nothing. We need many, many more labs and tests to be done. IPAC is increasingly getting noticed as an innovative model for private sector engagement. WHO Global TB Report ran an entire section on IPAC this year. So we are pleased with all of that, but I think there are major challenges involved. I think we need to improve notification from all IPAC labs, which is exactly what Dr. Gupta just said. RNTCP needs to know. That doesn't mean they want private sector patients, but they want to be informed and be made aware. And I think Dr. Gupta's point is also very valid. Good diagnosis alone is not enough. You could diagnose TB using Gene Expert and completely botch up the TB treatment. TB treatment and treatment completion are as important as diagnosis, which is the article that is in your packet that is coming out tomorrow on World TB Day. The tuberculosis control needs a complete solution. Exactly what Dr. Gupta said in a very different way. He said, give people a complete meal. Just don't give them an appetizer or the dessert. Give them everything that makes up a meal. This is exactly what TB control needs. TB control needs a complete solution end to end. Start, diagnosis, treatment, adherence, notification, completion, cure, and then they are off your books. And that's exactly what we need to do. So which leads us straight to the next talk on notification and treatment. So I'll stop here. If there are any one or two very quick questions, and I'm happy to take them. Otherwise, I can discuss with you offline as well. Any questions? Yes. So, like I said, WHO now has formally reviewed the evidence for Gene Expert for childhood TB, and it is formally endorsed for that reason. And it seems to work very well in gastric juice aspirate samples, which we didn't show you because it was not part of our analysis, but WHO has reviewed it. So pediatric TB is officially included in the WHO Gene Expert policy. But beyond that, I'm not aware of any breakthrough in pediatric TB. That's the only technology that's come through.
See, the other problem comes from the accessibility of the samples. Once you have the specimen, fine, you can go to the Gene Expert. Even people with pulmonary coughs may not have productive sputum 1. People with mediastinal lymph nodes and all keep going. We keep treating them cough versus sarcoid, ATT with steroid. You may not be able to access those nodes. And the biggest problem, what I feel as a clinician, is urogenital tuberculosis, particularly genital. They do endometrial aspirate, do PCNR positive, ATT started. I don't know. What's the solution to that problem?
I mean, it's a vexing issue, and especially for infertility workup in India, every OBGYN is obsessed about TB. And they send you, Surya is laughing, they send you endometrial blood and menstrual blood, and they're trying everything possible. I think the only thing I can think of is get a piece of tissue and then biopsy it, culture it, Gene Expert. That's about all you can do. Beyond that, there is nothing available as of now today. So it's an unmet need, and there isn't an easy solution to the problem. Any other final questions? All right, thank you.